Okay, so welcome to NeuroVerge number 3. We're just about to kick off the webinar with Dr. Brown. But before we get started, we just have a couple housekeeping things. So if you're new to here or you've joined us for the last two, I'd like to remind you that we're asking people to send your questions in a direct message to me. This way it avoids people getting overwhelmed and trying to keep an eye on chat and Dr. Brown's talk. This video recording and any resources that we talk about in this webinar will be emailed and posted in a few days. And I want to mention that's kind of key for this one because we are focusing on depression in this, but Dr. Brown's really going to take us on a journey and introduce us to the emotional regulation sequence. So it's a really dense and a chewy topic with a lot to cover. So things might go a little fast for you, and that's okay. That's why we record this and send it out again. It may mean that we don't have as much time at the end for questions either. So if your question doesn't get answered, not to fear. We've got them jotted down, and the appropriate person, Dr. Brown, somebody at Divergence, or myself, will reach out to you and make sure that you get that answered. So without further ado, I'm going to stop sharing and allow Dr. Brown to share his screen. So welcome, Dr. Brown. He's our Senior Chief Clinical Advisor at Divergence, among many other hats that he wears.
Thank you, Lori. It's good to be here. You mentioned this is going to be a dense presentation. I hope that isn't a reference to my intellect. It may be dense, but you're going to get some jokes here and there. So hopefully that will keep everybody interested. I am going to share my screen here and give you an idea of where we're headed today. Okay, unless I hear from you, I'll assume everybody can see this. Today we are nominally addressing neurofeedback and psychotherapeutic models for depression, but that's just going to be our kind of launching point because what I want to do in this webinar is to begin to lay out a framework for how to think about brain functionality. You may not be the phrase brain functionality or neurofunctionality and might not be rattling around in your head that often, but I find that not really having a clear picture of how the different parts of the brain work together, their kind of functional relationship, and how that ties to clinical work, how that ties to what we see in the clinic. Not having a clear sense of that really is a barrier to understanding neurotherapy and to being able to master it. So my maybe not so hidden agenda in these webinars actually is to cover certain thematic topics like depression and anxiety like we did last time, but also to dig a little deeper into what's happening beneath the surface with something like depression. So as Lori mentioned, today we're going to talk about something called the emotional regulation sequence. I kind of think of that as sort of the Rosetta Stone. The emotional regulation sequence is something that first was developed in the clinical world, the non-neuro world, and it has such a nice connection to what happens with brain functionality that I think of it as sort of the Rosetta Stone. It's sort of a way of cross-translating those two worlds. So I'm hopeful that today you will maybe feel a little bit challenged because we're going to cover a lot of material today. You might want to listen to this a couple of times. Although if you're just listening for my jokes, maybe once is enough. And my hope is that you'll begin to get familiar with this idea of the emotional regulation sequence because it sort of provides a bit of a schematic for how to think about the brain and how to think about the data that you're working with, whether it's the TheraQ or one of the other assessment systems. Okay, so today we are over here. Our topic is depression in the brain. You all, those of you who have been in some of the previous webinars, know that I set myself a personal challenge of being able to offer a definition of neurofeedback in 90 seconds or less that you might feel free to borrow for use with your own patients. I have been given the feedback that I have failed miserably in hitting the 90-second mark the last two times. I think I'm going to bring the average down. I've got a pithy way of describing neurofeedback that works well, I think, particularly for non-technically minded patients. And I'll give you that definition in a moment. Today, after that, we're going to look at depression through the lens of traditional psychotherapeutic models that some will be familiar to you. Most should probably be somewhat familiar to you. And then we're going to move from that traditional psychotherapeutic perspective and begin to look at depression through the lens of the brain itself. That's where we're going to explore this emotional regulation sequence that, again, was initially developed without overt reference to brain neuroanatomy or functionality, and yet it maps very well. We're going to talk about treatment implications for a brain-based perspective on depression. Many of you know that one of my kind of favorite topics is the idea that understanding something about the brain will make you a better clinician. We're going to talk about that in the context of depression. I have a case example that we will go over so you can see how the data can, from the TheraQ in particular, the assessment tool that Divergence has, you can see how that maps and gives you some guidance in both a neurotherapy and a psychotherapy direction. And then finally, we have some events we want to talk with you about that are coming up and some time for a Q&A. So I'm going to move fairly quickly. I will mention just in passing, if you look on the right, you'll see some topics that are coming up here over the next several months. And in them, I am going to continue to have this sort of subtext of trying to build out a model for neurofunctionality. So hopefully you'll learn something about these themes, but also something a little deeper. Okay, neurofeedback in 90 seconds. This is a metaphor that I use quite often with patients who are perhaps not very technically minded, and it is simply the brain as guitar. That looks kind of like a really bad omelet there, but that's supposed to be a brain that has been shaped into a guitar. Okay, the point of this is that guitars, any kind of music actually, functions within the context of frequency and amplitude. Frequency on a guitar would be the string that you're plucking. You can pluck a G string, that's a frequency. You can pluck an A string, that's a different frequency. It's the vibrations of the sound waves. Amplitude is how loud you strum or how loud you pick that particular string. So that's kind of an interesting way of thinking about frequency and amplitude, because at a very important level in terms of physics, that's exactly what's happening with the brain. We have variations in frequency and amplitude, and the brain, just like a guitar, can be either in tune or out of tune. This metaphor is also pretty helpful in explicitly pointing out to people that if we see red or yellow zone scores in your TheraQ, for instance, it's not an indication that your brain is broken. You want to make sure people hear that from you. This isn't about your brain being broken. It's about your brain being out of tune, much like a guitar can be out of tune. You can have the best guitar in the world, but if it's out of tune, it just isn't going to play very well. And so in a very real sense, what neurofeedback is a method of tuning the guitar and giving you back some of your capacity, some of your actual capacity. Most of the people that the typical neurotherapists work with do not have brain injury, they do not have a tumor, they're not having seizures, things that would be more indicative of damage. So we're generally talking about capacity and tuning that guitar. Okay, Nicholas Tesla has a little comment about that. I love this little quotation. I think he went on to develop an electric car, didn't he? I don't know. Okay, so I think I came in under 90 seconds. I'm sure somebody will tell me. All right, let's talk about depression. And you'll notice I've structured this webinar similarly to the last one on anxiety. Many of these things are going to be structured in this way because I want you to see common elements across these different topics. Depression by the numbers. I don't need to tell this audience that depression spectrum conditions are about the most common presenting problem you'll find in many mental health practices. In terms of the impact in America, in the United States, 8.1% of Americans have experienced some form of clinically significant depression at some point in their lives, not even mentioning subclinical depression. Only a fraction have actually received treatment. Some of the estimates of that are around 20% have actually received treatment. Women are more than twice as likely to experience depression as men. There's a lot of interesting research about that in terms of gender differences. 80% of adults with depression have reported at least some impact on their lives. So this is a condition that, again, I don't have to tell this audience, has a very real impact on work, on the economy, on family, on relationships, and personal well-being. This is a condition, if we can find some way to move the needle even a little bit in terms of depression in the general population, it will have massive positive effects. Sadly, we've had the opposite happen in the last several years with the pandemic. The pandemic, for reasons that may become clear as we go into some of the content this morning, the pandemic has really spiked depression, particularly among young people. And so these questions become particularly acute. And honestly, one of the reasons I just have renewed my interest in neurofeedback over the last several years, because it becomes a way of offering aid to people who might not otherwise be able either to afford traditional psychotherapy or even access it because they live in rural areas and so forth. This last statistic kind of reflects what's happening in from the pandemic. Between 2007 2016, the incidence of depression was pretty stable across age groups. You had about the same level of depression. Since 2019, rates of depression have increased by a quarter. Well, what happened in 2019? They call it COVID-19 for a reason. That is definitely one of the lasting impacts, in fact, of COVID, because those rates have not come down, to my knowledge. All right. Let's just touch on depression from a psychotherapeutic perspective, looking at these different models of psychotherapy and what they have to say about depression. And you'll notice these are the same 6 types of psychotherapy models that I used last time in discussing anxiety. You'll notice each of them has a different way of getting at what the essence of depression is. For instance, an existential model tends to focus on meaning and purpose, that without meaning, we as human beings tend to slide into despair. So an existential psychologist will tend to focus on meaning. Humanistic psychology tends to revolve around the idea of authentic self and whether they are living in a way that is congruent, whether our patients are living in a way that's congruent with their authentic self. Sort of sets up a tension between authentic self and societal demands. And that gap, inside that gap, is the potential for depression. Psychodynamic theory, as most of us know, focuses more on unresolved internal conflicts that have to do with our map from growing up, have to do with early experiences that we are still somewhat driven by. Internal family systems sort of updates and evolves that perspective and is looking at different parts of a person's self, looking at what some psychodynamic object relations folks would refer to as objects, intrapsychic objects that can be in conflict. Interpersonal psychotherapy focuses more on the role of relationship in producing an experience of depression due to conflict in those relationships, either historically or currently. Cognitive behavioral therapy focuses, as most of us know, on the role of negative cognitions that are not rational or not useful to the individual, that become habits of thinking. It's based on the notion that we respond actually to those beliefs that we have, and not so much to the outside world, but to the beliefs we have about the outside world. And to the degree that those beliefs are not rational or not useful, that's the degree to which we might be prone to moving into a depression. Okay, We could spend 6 webinars talking about each of those. I probably have not done justice to any one of them with that little thumbnail description, but I just want to kind of remind you, thinking back to your grad school days, of these different schools of thought. And I'd like you to consider what they might have in common, kind of across them. And you don't have to consider long, because I'm going to suggest something that they tend to have in common. And we'll get to that in just a moment. Most psychotherapists find validity in all these different perspectives. We tend to find a home base and maybe borrow from the others from time to time. There is not a clinician that I know who's been in practice for any length of time that doesn't at some points experience a certain amount of frustration with their own model. They may still believe in it. They may still feel like it has a lot of explanatory value, but they run across some clients for whom it just doesn't seem to work, whether they are cognitive behavioral therapists or humanistic or so forth. They often find that their tool is not always the right tool for that patient. And sometimes we can get a little stuck looking for something that will actually unlock things for that patient. Your experience, any of that, I think you're in the right place here, because while it is valid, absolutely, to consider other psychotherapeutic models, it is also very valid to think about brain functionality and what might be happening under the surface with that client that is not responding in quite the way you might have preferred. So any of us as clinicians can benefit from a deeper understanding of what's happening in the brain that basically creates the underpinnings for cognition and behavior and emotion, as well as actually having a tool to intervene at that level. And that's, again, why we're here today. Now, this deeper understanding of how brain functionality relates to the psychological models of self and depression, to look at the link between those two things, in my mind, requires us to look at 2 important concepts with respect to depression. The first is learned helplessness, and the second is this thing I've been mentioning here, the emotional regulation sequence. So let's start with learned helplessness. And learned helplessness, this has emerged out of cognitive behavioral and related disciplines. Learned helplessness is a condition that most theorists tend to accept as a basic, maybe not an exhaustive, but certainly a basic model for understanding depression. Here's a definition. Learned helplessness is a state that occurs as I experience a stressful situation repeatedly, and I come to believe that I cannot escape. We literally learn to become helpless if we're in a situation where whatever we do, we're not really able to move the needle for ourselves. Somewhat more formal definition, learned helplessness is rooted in a belief based on experience that I'm unable to control or change my situation. So eventually I don't even try, even when opportunities for change become available. This idea of learned helplessness started in the lab. We have that cute little puppy down there to kind of represent that. There were many lab studies in which they would teach a dog that if he was on that one side of the cage, you'll notice there's some electrical material that's down on the floor. If he's in that cage on that side, eventually that floor would become electrified. The dog would jump around and be uncomfortable. Eventually would jump over to the other side of the cage, and it's not electrified over there. That dog learns very quickly the opposite of learned helplessness, something we call efficacy or agency. And that's the idea, this is a difficult situation. This is a strange cage I'm in, but there's something I can do to improve my situation. All I have to do is jump over the fence. Beyond that, you can teach that dog to pay attention to this little traffic light here. And as long as it's green, he's fine. There's no problem. There's no electricity in the floors. If it turns yellow and then red, it's going to be electrified. That's a dog that learns very quickly that when the light turns yellow, jump the fence and you'll never experience a shock. That ends up being a perfectly well-adjusted dog. He's just in a very strange situation, but he's figured it out. He's kind of beat the system. And that dog has learned agency. He or she has learned that there is something I can do. I have learned this based on experience, that there's something I can do to move the needle in a positive direction for me. And so when we experience agency like that, you might think of it as kind of white blood cells for our sense of resilience. We become very resilient if we have that belief that there's something we can do to move the needle, even a little bit. We may not actually solve the problem. This dog didn't solve the problem of the electricity. He just learned to jump the fence early. If we have that sense of agency, we are very resilient. On the other hand, if we go through this experience of learned helplessness, we are at much greater risk for depression. We're at much greater risk for a lot of negative outcomes. One of the things that happens with a dog, and it's got an analogy with people too, is if that dog is now in a situation where either side of that wall, he's going to get shocked. Eventually he gives up. Eventually just curls up in a corner and withdraws and does all the kind of doggy things that one might expect if he were depressed. He's learned that there's not a darn thing he can do. He is going to be shocked no matter what. And that learned helplessness becomes actually a very difficult thing to unlearn. If you put the wiring back again, he's kind of curled up in the corner, but if you put the wiring back in again so that if he looks at the traffic light, he can jump over and avoid it, he will never know because he's not trying. Do you see the connection with maybe some clients that you work with where they have become so depressed that literally options are foreclosed? They have blinkers now. They're not really seeing that they might have choices because they have literally learned helplessness. Okay, that's a clinical concept that has been developed independent of the neurofeedback world, but it's very useful in understanding depression, both clinically and, as we'll see, in terms of neurotherapy. So let's move to the next step and begin to talk about the emotional regulation sequence. It's hard to talk about depression without talking about emotions, and it's hard to talk about emotions without really giving some thought to what are they? What is an emotion? What is there a purpose to it? Why do we have emotions? Now, I want to show you here, I deliberately did not give the citations for these top first two definitions because they are on the internet. They're on some actually fairly reputable sites, and they both are kind of terrible. So I'm going to start by defining what emotional regulation is not. Here's the poor definition. Emotional regulation is the ability to exert control over one's own emotional state. Well, that might be true as far as it goes, but it kind of begs the question, why do we have emotions in the first place? What is this just, are emotions simply something that we have to exert control over? That seems quite inadequate as a definition for emotion. A somewhat better definition is the second one. Emotional regulation is a term that's used to describe a person's ability to effectively manage and respond to an emotional experience. It's kind of a step in the right direction, but it's still about managing the emotion and not looking at the possibility that there is some kind of adaptive value to an emotion. Now, the next question will begin to kind of show my cards here a little bit, because I make no bones about it. I tend to think about these things from an evolutionary psychology standpoint, and that's very helpful clinically. It's very helpful from a neurotherapeutic standpoint as well. And you want to begin to ask the question, what's the role of emotion? What adaptive value, what survival value does emotion have? If it's simply something that is, if anything, disruptive to our equilibrium and disruptive to adaptation, evolution would have probably shaped us out of that. So what is the functional role of emotion in human adjustment? Well, here's some content for you to think about. This would be a definition of emotional regulation that's rooted in an evolutionary perspective on neurofunctionality, which, by the way, we will dip into quite a bit more deeply in a couple of months from now. So first point, emotional regulation is an adaptive process that has survival value. If it's something that has persisted over 500,000 years of human evolution, and lots of evidence in other species as well, then this is likely something that has adaptive value. Secondly, emotional regulation is a sequence of brain events, some of which we can experience consciously. We experience emotions consciously. We experience thoughts and other things that precede and follow emotion. But fundamentally, I would suggest to you that emotion is something that arises as a consequence of brain events, and we're going to talk about those in a moment. This sequence, this emotional regulation sequence, actively incorporates emotional content into, here's a 50-cent phrase, a complex affective, cognitive, behavioral process that has evolved to promote adaptation and survival. When emotions are properly managed, properly regulated, they become essential to promoting adaptation and survival. I sometimes use the analogy with my patients that back in the day, we had cars that had these little red lights on the dashboard. We actually called them idiot lights. And these are the lights that would go off when there was something wrong in your engine. It didn't tell you what, right? It just told you there's something wrong. It might be that you don't have enough oil. It might be that you don't have enough water. Maybe your pistons are jammed. Something's going on here, and you need to get out, pull over, pop the hood, and see what's going on in the engine. In a very real way, this is sort of the role of emotion, I believe, that emotions have evolved as a way of kind of giving us an early warning that there's something going on here, either internally or between you and your environment, that you need to pull over, pop the hood, and pay some attention to what's going on. And if you don't, you're going to end up with some pretty serious dysregulation. Final point, dysregulation of the emotional sequence can lead to reduced capacity to adapt to one's circumstances. When we find a way to become aware of emotions, to get some understanding of what the triggers are and what our choices are in response and so forth, then we are more likely to be interacting with the world in a way that is more productive for us, in a way that will lead to a greater sense of efficacy. If we don't, if we have a breakdown in that emotional regulation sequence that I just described very generally, we'll get into more detail in a moment. If we don't do that, we become at much greater risk for having a behavioral and cognitive and affective pattern that is not helpful to us. Okay, that's sort of 30,000 feet. Let's drop down a little bit. And I am going to suggest to you a way of thinking about the emotional regulation sequence in 9 steps. This is based, by the way, on a number of studies and theoretical papers in clinical psychology. Heather Cattell would be one of the psychologists. There are quite a few others. I've adapted these somewhat, but not very much. These 9 steps, I think you'll see, make a certain amount of sense from a psychotherapeutic kind of conscious mental standpoint, and we'll see in a moment they make sense from a brain standpoint. Okay, if we're going to manage our emotions, if we're going to regulate our emotions properly, where do you start? Well, you have to first become aware that you're having an emotional response. And if you're thinking, as you hear me say that, about the idea of dissociation, you're right. Dissociation would be a breakdown in the emotional regulation sequence at step 1. The person's not even aware they're having an emotion. So I have clients, I imagine you do too, who it's very difficult for them to recognize they're having an emotion. As we go through this, I'm going to give you an example, a real life example from a patient I had a little while ago who told me a story, and I'll just fill in the story as we go through these 9 steps. He said that, I realized I got into the afternoon yesterday and I realized I'd been angry all day. And I hadn't really understood why, what was going on. Well, he was dissociating. He was not connected to those emotions. We had a breakdown at step 1. So what's step 2? What's the trigger? We all do this in different ways, but in one way or another, we then, once we become aware of an emotion, we are going to try and understand what caused that. Why am I feeling, in my client's case, why am I feeling angry? And this is a stage in which you consider alternatives. You start generating alternative possibilities. Those of you who are in the training with me, neurofeedback training, may have heard this example before, so bear with me. This particular client, he realized he'd been angry all day. So he stepped back and he said, well, what happened earlier today that might have made me angry? He started generating alternatives. Well, the traffic was terrible. The barista got my order wrong. And this guy in the parking lot said something to me. Okay, so that's considering all these different steps. What happens next? You select the most congruent trigger. By congruent, I mean the trigger that makes the most sense to you, that resonates with your experience. For him, he thought, well, traffic's always kind of bad. Baristas always get my order wrong. It's that something about what that guy said in the parking lot. And what he realized was that was what had made him angry. He knew it intuitively. We're going to get very specific about where that emotional intuition comes from in a moment. The next step is, well, what did that trigger mean to you? This guy said something to you in the parking lot, right? So, and that made you angry. There's some meaning. This is a cognitive behavioral contribution here. There's some meaning I have attached to that trigger. Well, for him, he's thinking about what this guy said, and the guy said a few things, but there was something about where my patient was parked, and he said something about, you need to move your car over here, sport. He used the term sport, which is kind of an old expression. And as he reviewed that in his mind, he had something resonate in him, that sport, it's the use of the word sport. Now, nobody else would know about this but him. He knew that his dad, who had been abusive to him, always called him sport, and generally called him sport when he'd been drinking and he was not too many steps away from being abusive towards him. So you see, there's that echo now that he's now becoming aware of. And so at this point, we're selecting the most congruent belief. Okay, it's the guy in the parking lot. He called me sport. And now I think I understand, because he was reminding me of my dad, and it's putting me back in that feeling like I'm 8 years old and I'm scared, but I'm also angry. Well, what comes next? We're halfway through the emotional regulation sequence. What are we going to do? What's he going to do? So he told me, I considered my options. I thought maybe I'd go back down there and punch him out. Probably not a very good idea. I don't think I could even find him, and just not going to be very helpful, because I know it's not that guy now. I know it's kind of what he represented to me. I could just forget about it, or you know what, I could journal about it and talk to Dr. Brown. That's why I'm here talking to you. That's kind of the way he recounted this to me. So you consider, what are the range of possibilities? What are the range of things that I might do in response? Doing nothing is one, of course, but if you do nothing, it would hopefully be a choice. Otherwise, that's passive avoidance, which we wouldn't want. Step 7 is selecting an appropriate response from among that range. The fancy terms alloplastic and autoplastic simply mean those choices generally break down to a choice between changing other, alloplastic, or changing self, right? So I'm either going to try and convince my wife to do something that I've needed her to do, or I'm going to change myself. I'm going to change the way I think about her not having done that. It's kind of the two main buckets that we have in terms of choosing an appropriate response. Step 8 in the emotional regulation sequence is actually doing it, actually following through on whatever it is you have determined is the appropriate response to this whole cascade of emotional regulation. And I've put in here to implement and also sustain execution of the response. How many of us can relate to this personally and or recognize this in our patients, where we'll have somebody who works their way all the way through to this stage and they don't follow through? Or if they follow through, they can't sustain it. That's a pretty significant point for the emotional regulation sequence to break down at the very end. And we're going to actually, the case study is going to show us some of what happens often at the brain level when the client is experiencing that. The final phase in emotional regulation is assessing results. Did this work? Do I need to do more? Do I need to do something different? And so forth. And so we begin to have a loop that should characterize in a healthy individual the way they deal with emotions over the course of the day. Now, we're not thinking in terms of 9 stages. This is not always a full-blown cognitive process. Individuals experience this in very different ways. But this is a pretty commonly accepted general way of thinking about the emotional regulation sequence, these 9 steps. And I just put it here for you graphically. Yeah, you can see, it all starts with that awareness of emotion. Consider our triggers. You've got all those options. You pick the one that you want, and so forth. And you're just kind of creating a through line here that ends with, what am I going to do? Can I deliver that and sustain that response? And then finally, assessing the outcome, coming back and paying attention to what I'm feeling after having gone through that. Okay, I just put this here as sort of a visual for those of you who are more visual and less graphically oriented. Now, let's talk about this from a brain perspective, and this is going to get us into kind of the meat of things. We have here a schematic of the brain, and we generally, in the training that I do, the true bearing method that we teach for neurotherapy, we generally look at brain processes moving from back to front. So in the back of the head, we have the occipital region, somewhat the parietal. This part of the brain contains the hippocampus and the amygdala. Hippocampus generally is kind of where long-term memories are stored. So that's where my patient, he had a long-term memory of his dad back here. And the amygdala is the part of the brain that kind of adds the emotional valence to a memory, and the emotional valence to an event. So when he saw this fella, and this guy called him Sport, all of that started to resonate in the back here. This primitive alarm and this kind of emotional valence from the past starts to generate from back here in the back. The amygdala is extremely important when it comes to the kinds of things we deal with as clinicians, because it is the part of our brain that is generally adding that emotional valence to events. Okay, that's the back of the head. In the middle of the head, we've got this central region. We're basically talking about the medial part of the limbic system here, which is responsible for managing the fight or flight response. You can be in either a parasympathetic, relaxed, downregulated mode, or a sympathetic, upregulated fight or flight kind of mode. That is generally managed through here. And you can see how this does play a role in the emotional regulation sequence. In particular, anxiety is really driven through the midbrain. Last time, you may remember from the webinar last time, we talked about the role of the limbic system, the middle part of the limbic system in anxiety, because anxiety is essentially the label we give to activation in the midbrain when we move into fight or flight under certain conditions. Third area we're going to talk about is the anterior, the front, up in here. And generally speaking, we want to think about the right prefrontal cortex, the left prefrontal cortex, and the anterior cingulate, which is sort of right here in the middle. So very somewhat oversimplified. In fact, I mentioned down here, I have intentional oversimplifications here because at the end of the day, any model that purports to explain that the brain is always going to be an oversimplification, because the brain is a highly complex organ. We are simply trying to create models that will help guide us in the choices that we make as neurotherapists. So the right prefrontal cortex, generally speaking, takes the lead when we have divergent tasks, when we're trying to think about alternatives, to be creative, to think outside the box. Visuospatial reasoning kind of resides in this area. The left is more convergent thinking, coming to conclusion. You may start to hear some links with the emotional regulation sequence. Coming to conclusion, analytical, linear kind of thinking, that's more on the left side. The anterior cingulate is a very interesting structure in here that can be a little challenging to get to in terms of neurotherapy, but it is definitely possible. The anterior cingulate has a great deal to do with social intuition, with judgment, with motivation, and seems to be one of the areas that is actually implicated in that experience of efficacy. This is part of what has been termed the expectancy circuit in the brain, that when this is lit up properly, generally gamma frequency, we tend to have more motivation. We tend to be able to be more open to the possibility that our behaviors might actually have positive consequences. Okay, so let's not lose the forest for the trees here. We have these three areas: posterior, central, and anterior. And I'm just going to begin to map these to the emotional regulation sequence. And we're just going to jump right into it. I've got these 9 stages here, and I want to suggest to you the ways in which these either upregulate or downregulate given the demand. So in phase 1, awareness of emotion, you may have already guessed that the amygdala is probably involved in that, right? Because the amygdala is the part of the brain that is providing that emotional valence, giving us an emotion connected to an event or an experience. So generally, what's required in phase 1 is to have a properly functioning back of the head. The amygdala needs to be functioning properly, not over-activated or under-activated. And it requires a certain amount of activation here in the midbrain. This is actually intended to be sort of a combination, bluish, which is referring to downregulation, and purplish, just to indicate that we need a proper balance. There are times when we're dealing with emotions where we need to be calm enough to let ourselves pay attention to what's happening. And this is generally the part of the brain that is active when we become aware of emotions. Awareness of emotion is not a frontal thing. We're not talking about thinking about emotions. We're talking about experiencing them. This is a pre-verbal kind of function. And so that's where these 2 parts of the brain tend to become activated. Okay, what about step 2? We're considering triggers. Now, I want you to begin to think about these regions not as being binary, like one region is doing all the work, with stage 2, for instance. This is more like a jazz combo, right? These are musicians, and they are kind of a leaderless group. There's not a conductor. Every now and then, one of them takes the lead and kind of does what it specializes in. In the case of considering triggers, the front right is going to be necessary. The ability to think about alternatives. What was the trigger? Well, the barista that was incompetent, the bad traffic, right? That's a front right. That's a thinking kind of task that requires thinking divergently. So we tend to think of the front right as becoming activated there. Well, it's not just getting activated in a vacuum, it's listening to the amygdala. There's a conversation going on back and forth between the amygdala and the central region to identify what those triggers might be. Now we move to select a trigger. And now that is convergent thinking. That's coming to conclusion. That's making a decision. And that activates the front left. The front left also is not operating in a vacuum. It is also listening and interacting with the occipital, the back of the head, and central region. Okay. because when he hit that point where he realized it's the guy in the parking lot, that called me sport, that's not something that's not a conclusion he came to logically. That's a conclusion he came to because the back of the head is saying it's the guy in the parking lot. That's the amygdala that is drawing on those old memories and is carrying that association. And the front left is just simply kind of taking the lead and organizing this part of the process. Okay, now we're going to go to step 4. And by the way, you may notice even the way I chose these verbs, we have little pairs. We're considering triggers, selecting triggers, considering the meaning of the trigger, selecting it, consider, select, right? We have these little sequence of doublets, little pairs that occur here. So we move to consider the meaning of the trigger. Okay, he called me sport. What is that about, right? What does that mean? Well, you have to think about alternatives, right? And so sometimes it's difficult to really understand what an event means. If you have somebody who comes up and slaps you on the face, you might think, I'm angry because this person has assaulted me. Well, maybe there was a poisonous fly on your face and he actually saved your life, right? Sometimes we need more information and we need to think about alternative possibilities. It's kind of a silly example, but it's sort of a cognitive behavioral therapist's favorite example to illustrate that. Okay, we want to consider the meaning of the trigger, and then we have to select a congruent meaning, okay? He called me sport, and the reason that kind of lights me up is because my amygdala is reminding me that my dad called me sport just before he was going to beat me up, okay? I want to point out I've turned this central region into blue to kind of suggest downregulation, because in order to make these kinds of judgments, you have to be physiologically calm to a certain point. Just take a deep breath, just breathe, and kind of think your way through what's happening. When you find yourself instinctively needing to do that in order to process a complicated emotional event, that's what's happening is you're kind of trying to downregulate this part of the brain that is responsible for fight or flight. Okay, let's go to step 6. Well, what am I going to do about it? Do you see a pattern here? We're now back to the right. We're generating alternatives. We're thinking divergently about different possibilities. Okay, and then we move to picking the congruent response, the response that matches your experience in relationship to these events. Okay, then we move to delivering and sustaining the response. And you notice I kind of lit the central section back up again because quite often acting requires some level of arousal. If you have to go back and talk to your intimidating boss, you kind of have to get up for it a little bit. You kind of need that. You kind of need a certain amount of that fight or flight response at that point, not to punch him out, but to be ready physiologically to have that difficult conversation with him. Okay. I'll just say parenthetically that you notice I'm talking about these regions need to shift from time to time. And this is another whole topic, but I would suggest to you that the ultimate goal in terms of brain functionality is flexibility. It's for the brain to be able to shift from one state to another, depending on what is demanded at that moment. Okay, so we're at step 8, deliver, sustain the response. This is a really important part of the emotional regulation sequence, because this is now when it becomes external. You're actually, well, it could be internal. You may decide that I just need to change the way I think about this. That's a possibility. But quite often it calls for some kind of action, some kind of engagement with the outer world. And that's a different kind of challenge. Finally, we have evaluating the outcome. And that pretty much brings all of these things into play, because here's where we're listening to our emotions, way back here in the in the occipital region. We're asking ourselves, did that work? I went and I talked to Dr. Brown about this experience with the guy that called me sport. I feel like I have a lot more insight. It showed me that these other relationships where I'm a little bit annoyed and a little bit angry, I'm kind of doing the same thing. And so maybe there's some actual choices I want to make with those people because they're continuing relationships where the guy in the parking lot was not. Okay. Those are the 9 steps. I went through them very quickly because because of time, and I think we are going to have time for questions. I'm just going to land the plane here. I do want to point out any one of these steps can fail. And when you have a point of failure, you have a breakdown of the emotional regulation sequence, and you are likely to have some negative consequences out of that. Some emotional, you may move towards increased anxiety, you may move towards depression, you may move towards behavioral outbursts. This is when we start getting into clinically significant areas, when we get a breakdown at one point or another in this sequence. So I hope you kind of understand that if we can identify the parts of the brain that seem to be breaking down, and we can go a long way towards identifying those by looking at the assessments that we can do. It gives us some areas to explore in terms of how those areas of things breaking down in the brain may be related to what we see at the surface level with our client, and may suggest some ways we might intervene with them. In order to illustrate that, we're going to get to a case study. I just want to reiterate here, the brain's functioning more like a jazz ensemble, this leaderless group, and each of those parts are sort of taking the lead at different times. And we're looking for contextual homeostasis, which is to say a homeostasis that matches the situation. Okay, let's talk about a case example here for just a minute, and then we'll have time for questions. This is a 60-year-old male that I am actually currently working with. He's complaining of depression. There are multiple breakdowns in his emotional regulation sequence, as we can see in the EEG data. In particular, this is from the TheraQ. And I'm just going to point out a few of them. We're here in the back of the head, in the posterior. You remember, this is the amygdala, that whole area of the brain that we want to be appropriately regulated, so we're not having that emotionality on a hair trigger. The 2 things I'll point out here is we have a statistic here called alpha shift. This is measuring the brain's capacity to generate alpha when you move from an eyes open to an eyes closed state. That's kind of our way as neurotherapists of gauging whether there's sufficient alpha to calm that alarm. Alpha is a rest and repair state. It's the state that in the back of the head has this special role of calming that alarm, calming that emotionality down. And we're clearly in the red here with this gentleman. He's experiencing a great deal of free-floating anxiety. You may remember that from last time. He also has anxiety in addition to depression. And so this is just kind of adding heat to everything that we're going to see going forward in the brain. He also has very low peak alpha. This is the sub-frequency of alpha. And for the moment, the best way to look at this is getting at the efficiency of that alpha to calm the alarm. He not only isn't increasing alpha sufficiently, but it's the poorer form of alpha that the back of his brain is producing. Both of these, you take those together and it tells us that amygdala is a bit out of control, and that is going to propagate forward. It's going to create problems elsewhere. In the midbrain, we have this same alpha shift problem. In the midbrain, this has kind of the particular implication that the middle part of his brain, that part that's managing fight or flight, is not getting sufficient rest and repair. So it's going to tend to lead to dysregulation throughout that region. And we have it. TBR stands for theta beta ratio. This is kind of our Swiss Army knife little ratio that tells us about the relationship between a slow wave and a fast wave. Long story short, in this part of the brain, you want a low TBR. He has a high TBR. He has a lot of theta relative to beta. It means the middle part of his brain is experiencing dysregulation. And this is a real central part of the emotional regulation sequence. When you are in the red here, you are less likely to be able to process emotions in an effective way. Beyond that, when his brain's put under demand, he gets a little worse, actually. Well, he's still in the red, let's put it that way. And so this is suggesting more of an issue with concentration. We need concentration in order to be able to solve the emotional problems. He's having trouble with that. To be more specific, it's not just theta beta ratio, but the low beta aspect of the theta beta ratio is important. Low beta is sort of the mindfulness brainwave, and he doesn't have enough of that. Mindfulness is the ability to take in information without getting wrapped around your axle emotionally. He's not. Anything that happens, he's ruminating. He's just not able to move beyond it. Here's the part I want to show you that is really where we intervene to begin with, and this is this alpha symmetry. This is suggesting that there is too much alpha on the left side relative to the right. Now, we need alpha. Alpha is rest and repair, but you can have too much alpha. When you have too much, the region where you have too much is going to become inefficient. This is the front left. Do you remember from the charts a moment ago, the front left is very heavily implicated in the emotional regulation sequence. This is the part of the brain that decides what's the trigger, what are my choice, here's the choice I'm going to do, and allows you to follow through, implement a solution. This is a gentleman who is unable to follow through on solutions that he comes up with that would make things easier in his life. And when we experience that, here's the two themes in our webinar coming together. When he experiences that inability to complete, to follow through, he is going to experience learned helplessness. This is a phase where his brain is letting him down. Okay, his brain is not giving him the capacity that he actually has to be able to complete a sequence, to execute on a solution that he has. And you end up depressed when you have that happen enough, especially at a high level like this. So my initial strategy with him was to do what we call frontal stabilization, which is a protocol that we've developed as part of the True Bearing neurotherapy training that is designed to reduce this asymmetry and give him some of that capacity back. Okay, I could go on for another hour, but I think we better take questions. And I'm going to let Lori pick us up. I'm also going to let a little ad here for our next event. Just sit here while we take questions.
A bunch of questions came in that I think kind of all go together. Okay. So there was a lot of question around, I think, stemming from the last webinar coming together with this run around anxiety versus depression. So what people are asking was, which one do you attack first? Do you worry about which one is kind of the primary cause, or how do you go about when you've got kind of coexisting anxiety and depression?
I'm going to answer that two ways. When you do neurotherapy, you become a little bit MPD, a little bit multiple personality disorder. The clinician part of me would want to get very, very granular about DSM categories, whether it's depression or anxiety, and there is room for anxious depression in the middle of that. Okay, that's a whole conversation. But this webinar is neurotherapy, so I'm going to go over here. From a brain standpoint, it's all in a common root. Okay, anxiety is comorbid with virtually every DSM category that you can name, right? Imagine having a mental condition, unless you're delusional, that doesn't involve anxiety. When we're depressed, we're quite often anxious. Well, from a brain standpoint, that's because this midbrain, right, this is the part that is managing fight or flight. This is the part that when it gets activated, we tend to experience it as anxiety. This fellow is having a breakdown at almost every level of emotional regulation. He's definitely anxious because he's got this fight or flight thing going. His heart is beating a little faster. He's got, all this kind of activation. And he's failing enough at completing the emotional regulation sequence, especially there at the end, that he's also depressed. So I tend to think of, I'll now sit here in the middle, from a kind of combining those two things, I tend to think of Anxiety is generally about issues of threat of some kind. Depression is generally about issues of loss of agency, right? Loss of that efficacy that we've talked about. Those overlap. They inherently overlap. So it's difficult. I would say we need to kind of think about anxiety in kind of a pure form and depression in a pure form so we understand it. But the way these things occur in the wild is they co-occur. They co-occur because of the underlying brain functionality. It's all arising from the same kind of root. Hope that helps. There's about another 40 minutes I could do about that.
Yeah.
That's
We also have a number of questions coming in that came in during the talk and are coming in right now, wanting specifics around protocols. So could you address, what's the best resource for these people for that?
It's hard to find protocols that you can feel kind of confident about. Depends on the sources that you go to. I would say that the true bearing method, the training that we do, and I'll talk about that in a moment, the fast lane training that we're about to offer with Divergence, and we offer a version of this with other platforms. In my mind, I've thought a lot about this. I've been doing neurofeedback for about 40 years, and I believe that, along with a number of other psychologists, that when you're looking at site locations, right, they're boiled down to about 8 basic protocols that are going to cover the ground that most clinicians are going to deal with in their practice. So right now I'm answering that from kind of a functional perspective. If you want to know what to use, it boils down to about 8. We cover those in the fast lane training. But they're designed to basically hit the back of the head, this central region, the fight or flight area, and then the front of the head. There are variations of those 8, which probably bring you up to about 20. But once you kind of mastered the recipe for those 8, you can kind of just like a recipe, you kind of add ingredients as you go, depending on what you see in the data.
I think that is a good point to talk about what's coming up next, because that kind of leads into fast lane and brains happy hour, things like that. Sure.
You wanted me to talk about what's on the screen? We're all going to have happy hour. So many of you know that through True Bearing and with the participation of Divergence, we have been having these brainstorm events. We had one in Atlanta a couple of months ago. We're going to have one in Orlando that is going to co-occur with the AAPB convention. You do not have to have registered to the convention to come to Orlando. If you're within a state or two of Florida on June 1st, please come join us. Alex Nee, who's the CEO for Divergence, is going to be there. I'm going to be there. We're going to have a good time together. We're going to do some demonstrations of biofeedback as well as neurofeedback tech, so you can kind of get some hands-on experience with it. I'm going to be in a better position to describe the new learning resources through True Bearing Academy. I'll tell you a secret. We've been working so hard putting it together. I haven't had a chance to put together the advertising for it. So in the next couple of weeks, you'll see more about that. But we're literally taping every day right now, pulling together this educational resources. And finally, come just to get to know your colleagues. I know so many of you from around the country, from Canada, from Europe, and so many of you are living in the same community and you don't even know each other. So I hope you, if you can, I hope you have an opportunity to come to this. And there is an RSVP. You can't click on that link on your screen, I don't think right now. It'll be in the deck, but you can find it on the Divergence website.
We'll put it in the email too, so it's easy to find when we send the recording out.
Okay. This next one, yeah, there we go. This is for you, I think.
It's me. So our second marketing bootcamp happens on June 1st. And this is where we're actually going to jump into actually some hands-on stuff. So a little bit more like what you see in NeuroVerge. We're going to be talking about the warm-up getting your foundation of your marketing strategy, which is who are your clients and what are you going to offer them? And once you have that, how do you set your prices? Because, with all things being equal, it'd be nice to make a profit, wouldn't it? So how do we make sure that all those things happen? That's going to be happening on June 1st. If you haven't registered, you can register. If you can't attend live, of course, everybody who signs up gets a recording.
Great. This one we've already touched on. You will be seeing in your inbox fairly soon some information about fast lane divergence. Again, we offer training for a variety of neuro and biofeedback platforms, and I'm particularly excited to be able to bring this to the Divergence platform. This is going to be a training that will teach you the basic competency, tools for basic competency for neurotherapy. But also my intention is to give you some of what you need to integrate that into whatever form of clinical work you do, to make you a better clinician as well as a better neurotherapist. So that'll be coming soon.
Wonderful. Thank you, Dr. Brown. So just a reminder, we will usually we get the recordings out on Monday. Can't promise Monday because it's a holiday in Canada. So if you don't see it on Monday, you should see it on Tuesday. You'll have the links. If you are not a customer of Divergence Neuro and you have questions, info@divergenceneuro.com is the best place to get connected with us. If you are a current customer, you can use that one, or you can email us at support@divergenceneuro.com. We're not picky. If you reach out to us, we're going to help you no matter what. And then you've got the contact information there for Dr. Brown. If you're curious about True Bearing and you can't wait to hear what he's putting together, reach out to him. And both Dr. Brown and Divergence are here to answer any questions. So we'll see you in another month for the next NeuroVerge. And maybe in a couple of weeks if you're coming to the marketing boot camp. I see some questions came through kind of at the end. We'll circle back and make sure that we address those. So don't worry, we're not going to leave you hanging there. And hope everybody has a great day.
Mm-hmm. Good to see everybody. See you next time.
Take care.